So the first case is a patient who had a transurethral section of the prostate for urinary obstructive symptoms, very nonspecific. Most prostate biopsies and TURs, for the most part, I don't find clinical information very helpful. PSAs can be high, they can be low, and rectal exams can be abnormal, the MRIs can be abnormal, any imaging can be abnormal and normal. Most of these are just not very specific, so ultimately we have to rely on the pathology. So what we see here is a papillary lesion, very striking papillary lesion. As I mentioned, usual prostate cancer doesn't have typically a papillary pattern to it. That's not one of the classic patterns of prostate cancer. When we look at the cytology of these papillary fronds, again, it's not the typical cytology of usual prostate cancer, acute borderline. These are very pseudostratified, they're columnar epithelium. That's a classic findings of prostatic ductal adenocarcinoma. Prostatic ductal adenocarcinoma can have a range of cytologic atypia. Here we can see some having some prominent nucleoli, but if we move it around a little bit, some of these look more, the nucleoli are not as prominent. And that can be a problem. Sometimes some pathologists are not comfortable calling prostatic ductal adenocarcinoma when there's less prominent cytologic features. But architecturally, when you see these papillary structures lined by pseudostratified columnar epithelium, there's nothing else that this can be. This is prostatic ductal adenocarcinoma. Now, in the past, I would have looked at this case and said, okay, this is prostatic ductal adenocarcinoma, Gleason score 4 + 4 = 8, because that's what we call papillary prostatic ductal adenocarcinoma, Gleason pattern 4. But now, based on cases that I've seen and studies that I've done, I now recognize that prostatic ductal adenocarcinomas can uncommonly sometimes be confined only within the ducts and not be invasive, just like usual prostate cancer. So when I see a case that's not overtly invasive, such as this case with these exophytic papillary structures, I will do special stains for basal cell markers. And when you come here and do the basal cell markers in this case, you can see that basically all of these papillary structures are still kind of above the basal layer and are surrounded by a basal cell layer. So this is a rare case of prostatic ductal adenocarcinoma that's intraductal. It's non-invasive. In a sense, intraductal ductal prostate adenocarcinoma. So again, confusing terminology. Intraductal means location. Ductal adenocarcinoma is type of prostate cancer, cytology. What does this mean for the patient? 90% of the time, if they go back and do a repeat TUR, there's an invasive high-grade ductal adenocarcinoma component. And this is just a manifestation of the ductal adenocarcinoma growing into the ducts and kind of protruding out into the urethra. But in 10% of the time, that's all there is. It's all intraductal. Prostatic ductal adenocarcinoma in this patient is cured. So it's analogous to usual intraductal cancer. Ductal adenocarcinoma also can present very distinctly. So in a case like this is going to be a papillary tumor projecting into the urethra. To the urologist, this is going to look like papillary urothelial cancer, not like prostate cancer. The patients present with hematuria, normal rectal exam. So again, everything looks like it's a urothelial cancer. So be prepared that when you tell them this is prostatic ductal adenocarcinoma, they are going to be potentially confused and maybe say that doesn't make sense, and you have to explain this type of prostate cancer can manifest and present like urothelial cancer, but is in fact prostate cancer. Let me also, as I go through these cases, because they're all different types of cases, different types of organs. If you have any questions, just raise your hand and ask about them, because otherwise, I'll go on to the next one and you'll never get an answer. Yes?
Do you recommend repeat TURP in this case?
So it's a good question. The question is, do I recommend repeat TURP? I think that would be a reasonable thing to do, because if you do a repeat TURP, for example, there's nothing there, which is a potential, and then the patient, you wouldn't want a radical prostatectomy or radiation. And if you go back and do a repeat TUR and there's invasive prostatic duct cancer, high grade, yes, then that patient does need additional therapy. Okay, this is a patient with elevated serum PSA level. Again, nothing that's specific. And this is one of the things that I talked about earlier, so we'll go over it again, kind of go over it on a case so we can move the slide around a little bit. So what I see here at low power is I'm seeing some of these glands that look more benign architecturally. They're larger glands, some infolding, but they look darker. So when I see that, I think of PIN. So I think, okay, it could be PIN. But the other thing I'm starting to pick up on is that if you look along the edge of the core, you can start seeing that this long kind of cystic space here of similar type epithelium. So if we go a little bit higher power and look at these along the edges, we're seeing, again, this long, this columnar epithelium along the edge of the core. And if you kind of go up here, for example, that's, I think, nicely shows this columnar, darker cytoplasm epithelium along the edge of the core. So when I see that on a needle, as we talked about earlier, the thing to think is, could this be PIN-like ductal adenocarcinoma or a PIN-like cancer? Because PIN shouldn't be cystic like this. So in a case like this, you could raise the possibility of PIN-like ductal cancer on a needle, but you wouldn't be able to make a definitive diagnosis. So what you'd want to do is then do the basal cell stains. And when you do the basal cell stains, you can see all the glands in the middle that look more like PIN are entirely negative. And if we look at some of these glands along the edge, also they're negative, these big cystically dilated spaces. Like all along here, this whole big strip of epithelium is negative. So this is PIN-like ductal cancer or PIN-like cancer, and I would grade it as a 3 + 3 = 6. This is from another case to show in a radical what it looks like. So interestingly, in a radical, this radical had areas like this, which the glands look like PIN in that usual ductal cancer is going to be papillary cribriform. These are not papillary cribriform. These are individual glands that look like PIN. And then we come also over to here, we see these big cystic glands, which at low power you think, oh, that's just BPH, cystic big BPH glands. But when you look at higher magnification of these cystic glands, they're also lined by these columnar epithelium with cytologic atypia. And when you look at the basal cell markers, so first we go to the areas that were more crowded PIN-like glands. All of those are negative. But then even those big cystic dilated glands are all negative for basal cell markers as well. So this entire lesion here is PIN-like ductal cancer with these big cystic spaces. And you can, again, imagine if you stick a needle into something like this, you're not going to get the entire cystic gland on a needle. You're often just going to get those big strips of atypical epithelium along the edges of the core. So the main thing is to at least think of PIN-like ductal cancer as opposed to PIN when you start seeing cystically dilated, those strips of epithelium along the core, and do the basal cell markers. Okay, so this is somebody who had a history of prostate cancer. And I'm first going to show you cancer with treatment effect, and then I'm going to show you another slide from another case of benign prostate tissue with radiation effect that I think shows it better in terms of what benign glands look with radiation effect. So cancer that's been radiated, as I mentioned, sometimes the cancer will not respond to the radiation. It looks like usual prostate cancer. In that situation, you have no problems. You grade it just like usual prostate cancer. Diagnostically, you don't have a problem. It looks like usual prostate cancer. But sometimes cancer that is responded well to radiation doesn't look like usual prostate cancer. And what they often have is, first of all, very atrophic glands. They often have vacuoles in the cytoplasm. The nuclei often look very kind of pycnotic and not overtly that malignant. But architecturally, they're abnormal. This is not a normal architectural pattern of benign glands. And if we come over to here, these crowded clusters of glands are also not a normal pattern of benign glands. But if we were to grade this, we would grade this as pattern 4, because some of these glands are 3, but some of these look like more poorly formed glands. But, for example, in here, there's even some individual cells, some of these other cells with vacuoles, we would consider even pattern 5. But this is cancer with radiation effect. These patients, that means that tumors responded well to the radiation. This patient is likely cured by the radiation. So to grade this as pattern 4, pattern 5, obviously would be entirely misleading. So in a case like this, we just say cancer with radiation effect and don't give it a grade. If you do a pin 4 in cases like this, they basically light up with the basal cell markers. So if you go, for example, into or I should say not light up, they are negative for basal cell markers, light up, and they're positive for racemase. This case is not so positive for racemase, but you can see entirely negative for the basal cell markers. So you can always use the basal cell markers if you're questioning could it be cancer with treatment effect. When you're looking at a radiated prostate, you're basically looking for little clusters of glands with abundant cytoplasm, kind of pyknotic nuclei and vacuoles. Those are the clues that you're looking for radiated cancer. Now, again, remember that radiated cancer, often the cytology looks pretty bland. And often the nuclei look pyknotic and bland. In contrast, prostate tissue with radiation change, benign prostate tissue with radiation change, paradoxically, the cells look much worse than cancer. So the key thing with benign prostate tissue with radiation change is that at low power, the glands are still architecturally, spatially separated from each other in a normal distribution. So if you look here, you can see this kind of gland stroma, gland stroma, gland stroma. They're all spaced apart, not crowded, not irregular. So it's a normal architectural pattern. The glands tend to look very blue at low power because radiated benign glands are very atrophic. But what's very disconcerting when you go to higher power with radiated benign glands is you have tremendous cytologic atypia. But the atypia tends to be very degenerative in nature, smudgy chromatin, hyperchromatic. You can see nucleoli, so that's something just to be aware of. But many of the nuclei are smudgy. The key feature in radiated benign glands is that often the glands are multi-layered. You just move it around. So, for example, here you can see many of these glands are multi-layered. Also, in the same gland that you see big nuclei, you'll see small nuclei, so there's variable size. Whereas prostate cancer tends to be more uniformly all atypical. The other thing that we can see, let me see. So again, here are the big atypical nuclei in the same glands, are small nuclei, some with nucleoli, but some smudgy. That's characteristic radiation effect. Again, atrophic glands. Let me just see if I can find a situation with kind of more streamy cytoplasm. The other thing that you often see with radiated benign glands is that the nuclei often stream. Here we see a little bit. They almost look like they're streaming kind of parallel to the basement membrane. That's classic for benign prostate tissue with radiation effect as well. If you stain up benign prostate tissue with radiation effect, it'll light up with high molecular weight cytokeratin. So it becomes very straightforward if just doing the basal cell markers. Next case is a paratesticular nodule. It's labeled as paratesticular nodule, but it looks like it's more like in the testis. So what we have is a testis that's pretty much, you can't really make much out of the testis. We see this area of necrosis. So anytime you see necrosis in any organ system of the body, but now let's talk about the testis, you want to carefully look at it and say, what is this necrosis? Is it infectious, tuberculosis? Is it an infarct in the testes, which you can see due to vasculitis or the trauma? Or is it necrotic tumor? And so let's look at it a little bit at higher magnification. And what you can see when you look at it at higher magnification is that this is cellular necrosis. We can make ghosts of cells in there. When we use the term cellular necrosis, basically we're saying it looks like necrotic tumor. And in the testis, sometimes when you see cellular necrosis, you can actually make out even what type of tumor this is. So looking at this looks like seminoma. The individual cells, you can still see these big central nucleoli. But it's important to recognize and don't just call it necrosis or don't call it torsion or something else. And I've seen cases where pathologists have had areas where it was all dead and they just called it benign necrosis and the patient went undiagnosed for many years and developed metastatic disease. Now, one thing, we did a study on necrotic germ cell tumors, and even though they're necrotic, sometimes the germ cell markers can still be helpful. This is an OCT3/4, and even though everything's dead, you can still see that it's still trying to pick up some of the nuclei in this dead material. Obviously, its stains are not as good as if it was viable, but I still think given the morphology and the OCT3/4, you can end up saying that this is definitely necrotic germ cell tumor, and maybe you're not entirely 100% comfortable saying it's seminoma. I think it looks more like seminoma than ovarian cancer, but at least you can say necrotic germ cell tumor suggestive or in favor that it's necrotic seminoma. But the main thing is anytime you have necrosis, carefully look at it, see if it's cytonecrosis, could be necrotic tumor. The whole process or the phenomenon of regressed germ cell tumors, where germ cell tumors can totally undergo necrosis and scar down, even with extensive metastases, is sometimes you can have only the necrotic tumor, all necrotic, before it scars down into a scar, where you have to recognize it's dead tumor. Okay, so here's a kidney tumor that we talked about earlier. So, as I mentioned, we'll reinforce, I bombarded you with a lot of kidney lesions. So we'll go through one of these and see how we do. So what we see in this case is, first of all, we have this component, which is tubular. So as I mentioned, whenever you see a lesion that has clear cytoplasm, which this does with a lot of tubules, you should be thinking clear cell papillary renal cell tumor, not clear cell RCC. Clear cell RCC, typically you don't see a prominent tubular component. And then very nicely, I talked about how you have the subnuclear vacuoles, reverse polarity with clear cell papillary renal tumor. We have that here. You also have to have low-grade cytology. They should always look grade 1 cytology. Here we have a little papillary component of the clear cell papillary renal tumor. That's totally acceptable as well. And then, if you're not sure of it, the stains you want to do are CA9. It should be diffuse CA9. And we talked about the cup shapes. So to look at the cup shapes, you want to go into some of these little tubular areas. And basically what you're seeing is more staining along the lateral edges and not as much on the surface component. So for example, if you look at a cell like this here in the middle, you have staining on the sides and on the bottom, but not on the surface. So this good staining, and then the other thing that you want to do is a CK7. As I mentioned, clear cell RCC can be CK7 positives, low-grade ones, but never diffuse CK7. So if you see a clear cell lesion with diffuse CK7 like this, that's not clear cell renal cell carcinoma. You should be thinking clear cell papillary renal tumor, which is a benign entity.
Is this the same as what they used to call chromophil?
I have no idea what they used to call it.
You're telling me that I'm ancient.
No, I'm ancient too. Because when I started in my residency, when I started as a faculty in pathology, the way we called renal cell cancers, when I think about it now, it's laughable. We used to call them pretty much the same thing. We used to call them basically clear cell, kind of eosinophilic, mixed clear cell and eosinophilic, mixed cell clear cell and papillary. We would just, kind of put whatever we saw and wrote it out, as opposed to a specific type. So, and then they started having cytogenetics with trisomy 7 and 17, and we realized that's papillary, and lost 3P in clear cell. So, and then finally molecular came out, and now we have a whole different paradigm. Yeah, so I don't know what we called these things in the past. One thing that's interesting now, I go through, as I said, I have fellows that I train, and we go through some of my older cases, and I'm going through these older cases, and I say, oh, this is in ESC. but it was a 2009 case before ESC was discovered. So I look at what we called it, and most of the time we started off with peculiar, or unusual tumor that we don't know what it is, because we didn't know what they were back then. Okay, the next case is somebody with gross hematuria. And so what we have in this is a bladder biopsy. And the first thing you can see is it's very hemorrhagic. And this is an entity that is often overlooked, but important not to. So when you see a biopsy that has a lot of hemorrhage in it, and you don't really see anything, it's not tumor, and you don't really, you're not sure, just look carefully at the vessels and make sure that you don't have pink material around the vessels, which is amyloid. So this is cracking. You can see the amyloid tends to crack in little pieces around the vessels, which is classic. But amyloid occurs in the bladder, not that rarely. This one is basically around the vessels. Sometimes amyloid can be so extensive that it infiltrates the muscularis propria and can actually weaken the muscularis propria. These vessels are weakened, and you can actually have a significant hematuria with the amyloid. But it's something that, again, if you're not looking for it, if you don't think about it, you don't make the diagnosis, just like in a lot of parts of a lot of other organs as well. And then the other thing with amyloid is that I look for is, do I see a lot of plasma cells? So if I see a lot of plasma cells, I'll do kappa and lambda, but sometimes these amyloids will be associated with a light chain abnormality. But if I don't see a lot of plasma cells, I typically won't do the immuno. And don't bring up the issue that this could be associated with a plasma cell dyscrasia. This is the Congo red, just on the same case. You can see it's nicely staining some of this, staining those vessels. Next one is a papillary urothelial carcinoma of the bladder. So in terms of grading bladder cancers, when you grade bladder cancers, you grade them both, there's multiple factors that go into deciding whether something is low grade or high grade. First is architecturally, so low grade, the papillary fronds tend to be fairly distinct, not fused. So if I were to look at this biopsy, that would favor low grade. I look at polarity. Polarity means are the nuclei evenly spaced apart, relatively uniformly distributed, as opposed to clumped and irregular, kind of haphazard growth pattern. So I would say polarity is pretty well maintained. I look at the cells cohesive. High-grade tumors tend to be just like carcinoma in situ, they tend to start falling apart, whereas low-grade tend to be more cohesive. This is cohesive, so everything's going well for low grade. And then the final thing you look for is cytology. Are these all pretty, bland nuclei, or do we start seeing some larger atypical nuclei? And then when you go into this case, you say, this must be high grade because I see some of these big atypical nuclei. But when you look at these nuclei, that's not typical of a high-grade papillary urothelial cancer. Very smudgy, degenerative chromatin. Like if you were looking for mitotic figures, you wouldn't find any mitotic figures here, hardly any. If you did a Ki-67, which I don't routinely do in papillary tumors, but let's say in this case I might. If I did a Ki-67, let's actually look. I want to say if we did a Ki-67. So now you do a Ki-67, you say, okay, this is a tumor with all these big cells. Those big cells should be very highly proliferative. But if we look for the big cells, let's find an area of some of those bigger cells. In this case, you're always going to have some Ki, but what you want to look for are the big atypical cells, Ki positive. And you start looking here, for example, there's some of these big cells, they're Ki negative. And if you start looking over here, there's some more of these big cells that look degenerative, they're no Ki. So this is a case of a low-grade, non-invasive papillary urothelial cancer with degenerative atypia, mimicking a high-grade papillary urothelial cancer. And we did a study on this a little while ago and showed they behave like low-grade papillary cancers as well. So just a pitfall to think about when you're grading bladder cancers, that if you see atypia but it looks very degenerative, unaccompanied by mitotic figures, consider could this be degenerative atypia as opposed to truly a high-grade papillary cancer. This is the mass at the dome of the bladder. So when you're in the dome of the bladder, you have to think of potentially urachal lesions. And so urachal lesions, we all have basically we used to have a urachus that went basically up from the fetus to the umbilicus. When you're an adult, that tract becomes basically scarred down. It turns into the median umbilical ligament. But we can sometimes still have little urachal remnants, sometimes urachal cysts, and sometimes we can get tumors arising within these urachal remnants. Although the normal urachus is lined by urothelium, when we get neoplasms in the urachus, typically what happens is that urothelium undergoes glandular metaplasia. So most neoplasms in the urachus end up being glandular, either villus adenoma, adenocarcinomas of the urachus, less commonly urothelial cancer. But we can also get, here's a urachus, for example, here's the little remnant of the normal urachus, here, lined by some urothelium. So that's normal urachus. Here's some, again, part of our normal urachus. And what we can see here is this normal urachus now is ending up into this mucinous neoplasm. And mucinous neoplasm is lined by this mucinous goblet cell epithelium with some atypical nuclei next to it. But it's not overtly invasive. There's some mucin extravasation here, but if you look at this mucin here, it's acellular mucin. There's no epithelial invasive adenocarcinoma component. There's no epithelium floating in the mucin or lining this irregular mucin. If you look on another slide, and here's this extracellular mucin. Here's this mucinous epithelium, lined by kind of pseudostratified filament epithelium. Some areas it's very bland, lined by goblet cells. And the way to approach urachal lesions is you have to think of them as intestinal lesions, because basically that's what they are. It's intestinal metaplasia. So if you were to have this, for example, in the appendix, with this in some areas, very bland mucinous epithelium, other areas a little bit more adenomatous, filled with this mucinous epithelium. In the appendix, we would call this a lamin, low-grade appendiceal mucinous neoplasm. So basically, in the bladder or in the urachus, this is a low-grade urachal mucinous cystic neoplasm. So entirely analogous what you would see in the appendix. And because the urachus has all these tubules that are going in and out at planes of section, you have to be careful not to overdiagnose invasive cancer. All of these little outpouchings, there's no stromal reaction. Cytologically, they're not fully blown carcinoma. The nuclei are still oriented at the base. So this is all still a low-grade mucinous cystic neoplasm with extracellular mucin, not invasive adenocarcinoma. And if it's all resected, this patient should be cured.
And if you find epithelial cells within the extravasative mucin, does it make it malignant?
Yeah, if I saw little like signaling cells floating in here or little strips of epithelium in this mucin, yes, that would be a mucinous adenocarcinoma. So this is one of the more common lesions, that's stromal lesions I see on a prostate biopsy. So what we have here is a very cellular stromal lesion. And again, this is one of the most common kind of mesenchymal lesions I see in consultation. And the common question, it's reasonable, is this a stromal tumor? Is this a stromal tumor of uncertain malignant potential, a stump? Is it a stromal sarcoma? Is it a leiomyosarcoma? All this is stromal BPH. And that's why I see it commonly, because stromal BPH is common. So how do we tell it's a stromal nodule of BPH as opposed to a stromal neoplasm? And the key is actually not the stroma. The stroma, you can't tell. The key thing is the vessels. When you see these small capillaries that have a thick vessel wall around it, that's classic for a stromal nodular BPH. Normally, in any other tumor or any normal structure, with these thin little tiny capillaries, you wouldn't see this thick wall. The thick wall is disproportionate to the size of the capillary, and that's classic for stromal BPH nodule. The stroma itself can be extremely cellular. There's no atypia, there's no mitotic figures. Now, in a resection specimen, you would be able to appreciate that it's multinodular, which also would be the clue that it's stromal BPH. On a needle, you don't have that, so what you have to rely on is identifying those vessels. Immunostains aren't helpful. Stromal tumors and normal stroma stain the same, ER, PR, CD34 positive.
Would schwannoma come in the differential in this case?
Yeah, so schwannoma would be something that would be potential. So the biggest difference is schwannomas. Every schwannoma I've seen on a prostate needle biopsy has been extraprostatic. I don't think I've ever seen a schwannoma in the prostate. You can still see it on a needle biopsy because sometimes they go through, let's say, a needle biopsy nodule, but they think a nodule in rectal exam is actually a schwannoma outside the prostate. So it definitely is something sometimes you have to think about with a cellular spindle lesion if you didn't see those thick-walled vessels. So I talked about prostate cancer aberrantly expressing P63. So here, in this nodule, so until it kind of comes into focus, we have tumor that basically that looks classic for Gleason score 5 plus 5 equal 10. So prostate cancer, when it's high grade, cells still most of the time look relatively uniform. We have nice prominent nucleoli. This doesn't look like urothelial cancer. This looks like prostate cancer. So, and if I had this probably, as my own case, I wouldn't have done any stains. But this was stained at an outside institution. And they stained it for NKX 3.1. Well, I might have stained it, I can't recall. But here's the NKX 3.1. You can see beautifully positive. And as I've mentioned, this is a very specific stain. So, goes along with morphology. This is prostate cancer, no question about it. I mentioned the other marker, P501S. P501S is I also like it as a prostate marker because it has very distinctive staining. It has very clumpy, granular staining in the cytoplasm. So when you see this clumpy granular staining, you can feel more, it's real staining. Sometimes with immunocytoplasmic staining, you can get some non-specific blush. But with P501S, this clumpy staining, again, tells you it's real. So no question it's prostate cancer. NKX is positive, P501S, morphology is positive. But here's GATA3. Shouldn't stain prostate cancer, but you can see it even at low power. And I did this, with several stains just to make sure there was no no mix-up in the antibody. But this is, a prostate cancer that's aberrantly expressing GATA3. So it's uncommon, but it does happen, and it's just something to be aware about. Aware of that GATA3 sometimes. Most of the time it's focal, but occasionally like this, you can see diffuse GATA3 in prostate cancer. Okay, so this is a case, and I'll talk about this tomorrow as well, but we'll only go through it. So this is somebody who had hematuria. There was a small mucosal irregularity on his bladder. And what we see, first thing that catches your attention, if you only look at the epithelium, is you would say this looks like invasive urothelial cancer. You'd say there's nest down in the stroma, there's atypia there's atypia there, the pattern looks like invasive urothelial cancer, no problem. But with bladder, as I'll emphasize tomorrow, this is just a prelude, it's critical to look at the background stroma, look at the whole lesion, don't just focus on the epithelium. When you look at this, what's intervening between those nests, we see a lot of hemosiderin, we see a lot of red blood, and we see this pink acellular material, which is fibrin. When we have invasive urothelial cancer, that's not the background that we see with invasive urothelial cancer. Invasive urothelial cancer, most of the time you have no stromal reaction. At most, maybe a little sometimes cellular stromal reaction, but never hemosiderin, never fibrin, and never hemorrhage. So when you see these irregular nests that look like invasive cancer in the lamina propria with the background that I just described, that's not cancer. It's pseudocarcinomatous urothelial hyperplasia. And I'll talk about that tomorrow. It's associated with ischemia of the bladder, but I'll go into great depth on kind of the whole entity tomorrow. For now, I'll just cover, we'll kind of look at the morphology. But the problem is, out of context, if I just looked at any one of these nests out of context, it would look like cancer. So again, in bladder, the stress is look at the whole lesion, nothing out of context. So this is a lesion that we can see, a kidney lesion. We've now gone over it this morning, so you guys are all professional renal pathologists or neoplastic renal pathologists. So what do we see? We see solid, we see cystic, and we see... So it should be an ESC, eosinophilic solid and cystic. So the next thing we do is we go down and we look for those little purple stippled calcifications in the cytoplasm, and there's a bunch of them all over the place, these little purple little granules, and I just randomly went on some field, and they're there. So that's what this is, ESC. And if you look at the cystic area, very nicely, these little hobnail cells. So hobnail is actually a true nail. If you look up in the dictionary, it's a nail that the head of the nail, instead of flat, is kind of like bumped up round, and that's why we get these cells that have these rounded protuberances on them. But ESC is a low-grade carcinoma. It does metastasize, but uncommonly. As I mentioned before, associated with TSC mutations and mTOR mutations. Most of the time it's sporadic, but it's occasionally can be seen with tuberous sclerosis. So it's important to make the diagnosis. And then the only other stain you want to do is, again, there's really one stain, and that's a CK20. And that's the only time pretty much you'll hear anybody should be talking about CK20 in immunopathology. CK20 can be focal. In this case, it's actually quite diffusely spread out, or more than just a rare cell here and there, and that's definitive for this diagnosis. So everybody has CK20 as a stain. It's not a fancy stain. So this is a diagnosis, in immunopathology you can make without molecular. This is just a really weird case, but it was a fun case, so I thought I would show it. It's a prostate needle in a 9-year-old. So, who's getting a prostate biopsy with a 9-year-old? This was for somebody who had a big mass in their prostate, a boy, and what we can see are these little nodules that are little spindle cell nodules and myxoid there, another one there. Even if you look at, say over here, it starts as another little nodule, another one. So this is somebody with neurofibromatosis. And these are plexiform neurofibromas in the prostate. The only case I've ever seen. But they were ruling out, they wanted to rule out a malignant peripheral nerve sheath tumor in this image. And, S100 positive, as you would expect. So this is a case that's somewhat similar to what I showed, but a little different, that emphasizes when you're looking at prostate needle biopsies, you have to take into account everything, not just the architecture. Because if you were to look at the architecture of this case, you would say this should be prostate cancer. It doesn't look like any normal prostate tissue. Glands are crazy crowded, it's going all the way down this core. This should be prostate cancer. But that's, okay, at low power, that's maybe your impression, but let's look at it at higher magnification. So we look at higher magnification. In general, pretty bland, these little glands here. Not a lot of cytologic atypia. So you keep going down in some more of these glands, and you keep on looking for some cytologic atypia, but it ends up being that there isn't any. Keep going down here. Again, virtually no cytologic atypia. And then as you get down towards the bottom, you start seeing some of these glands start having maybe a little bit multi-layering to them, which is something you see more with basal cell hyperplasia. And finally, at the bottom, some of these glands start having some cribriform glands as well. Let me go to the bottom. Here we start seeing cribriform glands. You say, okay, that should be cribriform pattern 4 cancer. But again, you look at it, there's just no cytologic atypia. Now, this still potentially could be cancer. Some prostate cancers, you don't see cytologic atypia. But with all this cancer up and down this core, cribriform, small glands, the fact that we're not seeing any cytologic atypia is unusual. And you should ask yourself, despite being so florid, could this be a benign mimicker? Could this be florid adenosis and cribriform hyperplasia coexisting? And sometimes these various mimickers, adenosis, basal cell hyperplasia, cribriform hyperplasia, can all coexist in the same area of the prostate. So in a case like this, you, again, don't want to use your gestalt, oh, this looks like cancer. You have to say, okay, these are all the features that Dr. Epstein talked about favor cancer. And, there's just not many features favoring cancer in this biopsy, despite it architecturally looking so abnormal. In that case, you have to say, okay, let's step back, let's do a basal cell marker, and see if it stains like cancer or if it doesn't. And you can see even at low power, there's too much brown here. So all of these glands contain a basal cell layer. These are all adenosis, florid adenosis of the prostate, not cancer. And there may be one or two glands in here that are patchy, but are negative, but that's fine for adenosis. If you go down to the cribriform glands at the bottom, they also have basal cell layers. Now you could argue maybe that's intraductal cancer or AIP, but there's no cytologic atypia, so that's inconsistent with AIP. So this is cribriform hyperplasia. So this is a case of just extensive florid adenosis and some cribriform hyperplasia on the needle, where the low power looks like cancer, but then when you go to high power and try to find other features for cancer, they're not there, and you have to ask yourself, could this be a florid benign mimicker? This is a renal mass, and it has two components. So this one component, so my wife asked me to, made a point that I might be incorrect. So does everyone know what Swiss cheese is? Maybe people don't have Swiss cheese in Kuwait. Do you know Swiss cheese with the holes in it? Okay, fine. Well, I had to ask. So this is kind of a Swiss cheese area with these open holes. And if we would go down and look at them, just like the case I showed you, they're not normal. They have prominent nucleoli, they're irregular. So this area of the tumor is tubulocystic carcinoma. Again, think of tubules that are cystic, just the name. But tubulocystic carcinoma by itself should look just like this. Shouldn't have solid areas, shouldn't have more complex areas. Then we come to this area. This is too complex for tubulocystic. So this is tubulocystic carcinoma with poorly differentiated foci, what I talked about earlier. And when we look at this area of poorly differentiated foci, what do we see? These giant red nucleoli, these CMV-like, owl-like nucleoli. That when we think of that, we think FH-deficient renal cell carcinoma. And as I mentioned, some tubulocystic carcinomas, a large percentage, or about half of them, tubulocystic carcinomas with poorly differentiated foci lose fumarate hydratase. And in fact, in this case, when we did the FH stain, you can see beautiful loss in these areas with the big prominent nucleoli of fumarate hydratase. So this is an FH deficient RCC arising in association with a tubulocystic carcinoma, and we would basically say in our note, this could be associated with hereditary leiomyomatosis-associated RCC, HLRCC, but it could also be sporadic, and then it's up to the clinician to do genetic testing, see if the patient has, if it's a female, leiomyomas, and assess the patient to potentially germline mutations. So this is kind of a tricky case. Came as a prostate needle biopsy. So one thing you have to be careful about is that if you get something that's prostate needle and you look at it and it looks all kind of mesenchymal, it doesn't look like any obvious prostate cancer, and you don't see any benign prostate tissue, first of all, you always have to ask yourself, do I see prostate tissue? Because the pitfall is we all have tunnel vision. If something's labeled prostate biopsy, we think, okay, what in the prostate could this be? We're not thinking maybe it's not even in the prostate. Maybe it's a periprostatic lesion. So the first thing when you see something that doesn't look like any normal prostate tissue, it looks kind of mesenchymal, and then you step back and you say, I don't see any prostate lesion, you have to say, again, could this be a soft tissue tumor arising outside the prostate, either pressing the prostate or adjacent to the prostate? And what we see here are these small little spindle cell nodules in a myxoid matrix. And some of these spindle cell nodules start spinning out into these little fascicles, almost a little palisading. And this is a GIST, a gastrointestinal stromal tumor. And you think, why is it GIST on a prostate needle biopsy? We did a study of this a while ago, and the way they manifest, you can get a large GIST either rising from the rectum, muscle wall, or even the mesorectum between the prostate and the rectum. And that GIST can be so large that it actually compresses the prostate almost like a pancake. So and on imaging, they will think it's a prostate tumor nodule, as opposed to a periprostatic nodule. I've also had some cases where the urologist on the rectal exam felt a nodule, and he wanted to biopsy the prostate, and he kind of kept on trying to push the nodule away just so he could biopsy the prostate, and then went through the nodule, and it was a GIST. So you have to think of GIST, because it's just not in your differential diagnosis of a prostate lesion. But once we recognize that this might not even be a prostate lesion, and we see the morphology, these little spindle cells, you at least think of GIST. And then once you think of it, you can readily make the diagnosis. You have to be careful because CD34 is positive in stromal tumors of the prostate and GIST. So if you're thinking it's a stump, for example, stromal tumor of uncertain malignant potential, and you only do it CD34, you may go down the wrong path. So always think, could it also be a GIST, and do a C-kit, CD117. It's also reasonable with these spindle cell lesions to do an S100 as well, just to rule out a neural tumor. But, or you could also add a DOG1, but this is C-kit. Definitely, it's a GIST. So this is a bladder tumor, another bladder tumor. So at low power, a lot of this tumor is papillary. It's low grade. The nuclei is relatively uniform. Not a lot of mitoses. Polarity is maintained. So I won't go into that much, but this is a low-grade, non-invasive papillary urothelial cancer. So most of it's low-grade, not a problem. But the interesting thing about this tumor is that in the areas of this tumor, let me find the best area. So with many papillary urothelial cancers, it's very common to have inverted growth pattern. I would say it's just as common as the exophytic component. But with an inverted growth pattern, the inverted growth has a very rounded, smooth border to it, not irregular. There's no stromal reaction. There's no what we call paradoxical differentiation, where the tumor gets pinker when it invades. So right now in the field here, if I were just to look in this field here, this is all low-grade, non-invasive papillary urothelial cancer with just an inverted growth pattern. But when we look and come over to here, all of a sudden what we see here is that instead of these nice rounded nests, we're seeing very irregular raggedy nests. That's invasive cancer. So this is invasive urothelial cancer. But the unusual thing about this invasive urothelial cancer, it's associated with mucin, this blue-tinged mucinous material. And if you were to stain this up, it's mucicarmin positive, Gaussian blue positive, PS digest positive, it's mucin. And you say, why is there mucin with a urothelial cancer? You would expect mucin with an adenocarcinoma, not urothelial cancer. And the answer is, we did a study on this. It's unclear why, but bladder has tremendous capability of divergent differentiation. So even though on the morphology, the H&E, we don't see glandular differentiation, this urothelial carcinoma is divergently differentiating towards glandular differentiation and can still make mucin even in the absence of overt histological evidence of glandular differentiation. So this is a low-grade mucinous invasive urothelial cancer with mucin. It also brings up the point of grading bladder cancer. So 95% of invasive bladder cancers are high-grade. We call it invasive, high-grade bladder urothelial cancer, invasive high-grade papillary urothelial cancer. But sometimes we see invasive urothelial cancer, which morphologically is actually pretty low-grade. So what do you do in that case? There are different schools of thought. Some urological pathology experts, for example, when they see a case like this, will call it invasive high-grade cancer, even though morphologically it's low-grade. And the rationale for that is, biologically, it is high-grade. even though it's not that high grade cytologically, we're not seeing a lot of mitoses, etc. Once it invades, whether it looks low grade or looks high grade, it all has the same prognosis. So some of you all, again, experts would call this invasive high grade. I call this invasive low grade because under the microscope it looks low grade. But it can be confusing to clinicians. And I've seen clinicians, when they get a report of invasive low grade cancer, they think, oh, maybe it's not something to worry about, it's low grade, which would be misleading. So when I diagnose invasive low grade urothelial cancer, I add a note saying that even though morphologically this tumor is low grade, biologically it has the same prognosis as high grade stage for stage and should be treated as a high grade invasive cancer.
So do you say in your report it's focal or extensive, because that might make a difference?
Yeah, no, I do say so. Right. So it's a tricky area in bladder. So when you have invasive cancer, you should try to give the clinician some indication as to the extent of invasive cancer. There's no uniformly accepted way to do that. Sometimes if I can say it's above the musculus mucosa versus below the musculus mucosa, I'll do so. But sometimes you can't make out where the musculus mucosa is. There are sometimes when it's just very focal, I'll say focal invasive cancer. There are sometimes when it's extensive, and I'll say extensive to try to sensitize the clinician to that. There are other techniques that people have come up with by measuring how many high power fields, but none of them I've been very satisfied with. So I often will do it just subjectively focal or extensive. Now, ultimately, it shouldn't make that much of a difference, because even if they have muscular scopia on the resection, it's recommended they should go back and do a repeat TUR because of the potential of understaging. But I find sometimes urologists don't do that, and the literature shows they don't do that. So definitely when you have extensive invasive cancer, you want to let them know that to make sure they go back in those cases. So this is a hydrocele sac. So a hydrocele basically is just the mesothelium that's coming down from the peritoneum that goes down around the testes. And gets filled with fluid often. And it often becomes fibrotic and thick and just chronic irritation in the hydrocele sac. And so they take out the hydrocele sac and they drain the fluid. Where it becomes an issue for the pathologist is that it's not uncommon in hydrocele sacs to see florid proliferation of mesothelial tubules. And that's very concerning and can be difficult for pathologists to make the distinction, is this benign reactive mesothelial hyperplasia or potentially malignant mesothelioma? Because malignant mesothelioma can cause a hydrocele, and so both can present with a hydrocele, either reactive mesothelial proliferation associated with a hydrocele or malignant mesothelioma causing a hydrocele. And probably the best way to make the distinction is that in a florid reactive mesothelial hyperplasia, it's a very linear growth. So all of these tubules here are proliferating just in this linear array in between the kind of more densely collagen and the more inflamed collagen. And that's a classic histology for reactive mesothelial hyperplasia. Now, you can go down cytologically, and they also can look fairly bland. The problem is some malignant mesotheliomas can be bland. There are a couple of immunohistochemical stains. If you're not sure, they can be potentially helpful, but maybe not. MTAP is one, and BAP1 is another, where it's lost in 50% of malignant mesotheliomas. But the problem is the other 50% of malignant mesotheliomas, it's retained. So if it's lost, it's helpful. It tells you it's malignant. If it's retained, it doesn't help you. But again, I think most of the time it's the morphology that's helpful, that it's just this linear proliferation of glands, whereas malignant mesothelioma, the tubules tend to go down irregularly into the stroma. They tend to go down into the fat and not form this nice kind of just organized linear row of glands. The other thing I find helpful when you have a hydrocele with these is put through more, because often we just put through 1 to 2 sections, put through more just to make sure nothing looks worse on additional sections. This is a paratesticular lesion. You can see the testis is normal. So whenever you're looking at a testis orchiectomy or biopsy, you always want to separate out, is it paratesticular or intratesticular? Because often the very different lesions will enter into differential diagnosis. So in this case, we have a paratesticular lesion, so we don't have to think of germ cell tumors. Germ cell tumors only occur in the testis. And when you look at this, it's a very papillary lesion. And when you actually look at this at a little higher power, there's actually cilia in all of these little structures. So what is a ciliated, a cytologically atypical papillary lesion doing next to the testis? And so when you think of lesions that occur paratesticular, one general category you have to consider is Mullerian. Because basically both paratesticular, less commonly intratesticular, you can see the full range of Mullerian lesions that you would see in the ovary. You can see serous, mucinous, endometrioid, clear cell. It can be benign, adenofibromatous, borderline, frankly malignant. This case, I often share them with the GYN pathologist. Is considered to be a papillary, serous, borderline tumor. It has a nice little calcifications, classic for a serous tumor as well. Now, in terms of terminology, I would call this a borderline serous tumor because it's analogous to what we see in the ovary. But whereas in the ovary, when you have a borderline tumor, they call it borderline because they often can spread into the peritoneum and cause a lot of local problems. Turns out in the testis and paratesticular region, when they do an orchiectomy, they cure it. It doesn't go anywhere. These lesions don't spread anywhere. So I say, even though we call it borderline to be analogous to what we see in the ovary, this patient is 100% cured of this lesion. So they're not concerned about that. And they'll stain, Pax8, they'll stain just WT1, they'll stain just like any other GYN tumor. This is a penile lesion, and when you see a penile lesion, so with penile squamous lesions, there are several different types of invasive squamous cancers of the penis. There's usual squamous cancer, which is about 50%. There's a warty basaloid squamous cancer. There's a warty squamous cancer, a basaloid cancer that we'll talk about. There's verrucous carcinoma. But this is an example of a basaloid warty carcinoma that's non-invasive. So what we can see is some of it looks warty. By warty, we means it kind of has the spiky look like a wart. We can also see it has kind of hypergranulosa cell layers, just like a wart. But this is very cytologically malignant. So verrucous carcinoma looks totally cytologically benign. The only way you can recognize verrucous cancer is because it's pushing down deep. It wouldn't have this degree of atypia. So this is a warty carcinoma. And the basaloid carcinoma component is that it looks very blue. And these are the kinds of cancers that are very HPV associated, basaloid and warty. Usual squamous cancer is only HPV in about 50% of the time. Verrucous cancer is never, despite its name, is not HPV related. But here when we see this very basaloid proliferation, just like in the anus or the cervix, that's classic for a basaloid squamous carcinoma component. But this is all, you look carefully for invasion, but this is all non-invasive.
Is this microinvasion, that focus that you have just shown on the edge?
Yeah, I think there's little nests that grow down, but not definitively irregular. Some of this is, again, kind of rounded, so not definitively invasive. But, it might be reasonable. Man, most of this, I think, looks more non-invasive.
That's focus,
Yeah.
So the treatment for this lesion is just
wide excision. Yep, wide excision.
excision.
Yep, would be the last case. So this is the last case. It's a testis lesion. So one of the categories to think in the testis, if it's not germ cell tumor, is sex-cord stromal. So what we see here are these nice tubules. And when you see tubules with nice central nucleoli, that's Sertoli differentiation, just like a normal Sertoli cell. So this is a Sertoli cell tumor. But we also have this cellular kind of fibrous tissue that's basically indistinguishable from a fibrothecoma in the ovary. So this would be a Sertoli fibrothecoma. Totally benign. And the most important stain that you want to do with these sex-cord stromal tumors is SF1. A lot of these are inhibin positive, but inhibin to be negative. Steroid factor 1 or steroidogenic factor 1 is much more sensitive and is the best marker for sex-cord stromal. We'll stop with that. Thank you very much.